All right, we're going to get started. Good afternoon, everyone. Thanks again for joining us to our Center of Business Analytics Big Data University Speaker Series. Today's topic is the analytics in healthcare and life sciences, real-world data and AI in action. And today we have Ian Weimer joining us as the main speaker. Here in the Center of Business Analytics, we have a plan to develop a robust, industry-centered workforce pipeline in emerging technologies, benefiting regional employers as well as students who gain experience in high-demand, lucrative fields. Second goal is to advance industry-relevant research on emerging technologies, including artificial intelligence, otherwise known as AI, identified in partnership with industry partners and conducted by St. Mary's faculty, including joint research projects with industry and other university partners. And number three, we have to become a recognized hub for thought leadership and cross-institution collaboration in business analytics and technology. We are always looking for partners, sponsors, and contributors. Please contact us at cva@smumn.edu for more information. About our speaker, Ian Weimer brings 8 years of experience across data science, research, and business development to healthcare and life sciences analytics. After earning his MS in data science from DePaul University and a BA in biochemistry with a mathematics minor from St. Mary's University of Minnesota, Ian spent 3 years as a data scientist at Boston Strategic Partners, where he led analytics projects for Fortune 500 pharmaceutical and medical device companies. His analytical work contributed to 14 research publications and abstracts presented at leading conferences, supporting regulatory submissions and market access strategies using real-world evidence from databases including Optum, Oracle, and MarketScan. He funded Weimer Analytics to provide specialized analytics to expertise directly to healthcare and life sciences organizations. Weimer Analytics LLC specializes in advanced analytic solutions for healthcare and life sciences organizations. The firm provides expertise in health economics and outcomes research, otherwise known as HEOR, real-world evidence analysis, AI and machine learning applications, and regulatory analytics, working directly with pharmaceutical companies, medical device manufacturers, biotechnology firms, and healthcare systems. Weimer Analytics transforms complex data into strategic insights that drive regulatory approvals, market access success, and competitive differentiation. The company's approach emphasizes direct collaboration between data science expertise and business decision makers, ensuring analytical insights translate into measurable outcomes and, of course, actionable recommendations. A survey will be provided on the screen when this webinar ends as a little heads up and in an automated email. We're always on the lookout for guest speakers, as I mentioned previously, real-world projects, and other opportunities to connect with our students with industry. If you or your organization are interested in sharing your expertise or collaborating on meaningful experiences, we would love to hear from you. For more information, again, please visit or contact cva@smumn.edu and look in your email over the next 10 business days for a certificate of completion for this session. Now I will hand it off to Ian for his speech. Let's see.
Thank you. Thank you very much.
Of course. Now you can share your screen. Let's see if it
Great.
properly.
Can everyone see my screen?
We can see it.
Good. Good afternoon, everyone, and thank you to Dr. Rachajcek and the Center for Business Analytics for having me here today. It's great to be back at St. Mary's, and thanks for the introduction. So today I'll share real-world examples of healthcare analytics in action, discuss some of the consulting work I do at Weimer Analytics, and provide some practical published research examples. So I'll start with kind of some of my background, some context on my background. So as mentioned, I'm a St. Mary's alum. Graduated in 2016 with a biochem degree and a math minor. Um, I got my master's from DePaul in 2021, and then spent the 3 years at Boston Strategic Partners doing healthcare analytics, which included 14 publications and presentations. Clients were primarily Fortune 500 pharma and medical device companies. Um, but there was a mix also of some kind of medium to small sized like biotech and health tech companies as well. Before that, I spent 4 years kind of across research and analytical roles. So my work really focuses on turning this healthcare data into actionable insights for pharmaceutical companies, med device manufacturers, and biotech firms. Um, so just to go over the agenda. So first I'll explain explain real world data and why it matters, including privacy considerations. Then kind of get into 3 case studies from published research. These are real projects with real impact. Then we'll take a brief look at what working in the field actually looks like day to day. Go over kind of the company at Weimer Analytics and the services I offer, and then leave time for questions and discussion at the end. Feel free also to kind of put questions in the chat as we go. Um, uh, but we'll also have the dedicated Q&A time at the end. Um, so, so what is real world data? Um, so it's going to be data collected during routine healthcare delivery. Um, 1 second. So, I use kind of one big monitor, so I'm kind of having it on the small laptop. Some notes. So just if we start with the foundation, what is real world data? It's information collected during routine healthcare delivery. So as opposed to like doing studies on, you may have heard of like clinical trials. Clinical trials would be like non-real world data where, the product hasn't been released and isn't being used by real patients yet. So real world data is going to be collected from things like EHR, so hospitals and health systems, claims data coming from, large insurance companies that you may know. So insurance billing records, which include diagnoses, procedures, costs. You can also look at like visit types, um, like inpatient hospital visits versus outpatient versus ER. You can differentiate things like that. It can also come from registries. So um, there are registries for specific diseases, like specific types of cancers and other diseases. So that can be another data source. Another data source is wearable. So I use like Apple Watch every day, and it's collecting activity data and things, sleep data, things like that. That can also be another source. Um, I thought of another source that's not mentioned here, that's not in this list here is proprietary product data. So you can have, for example, like a medical device data that's such as like an infusion pump that delivers, medications to the patient. That can be another source of real world data. It's kind of like EHR. Sometimes it's integrated with like an EHR system, but sometimes it's not as well. So there can be kind of this proprietary product data also. Um, and at least I've done a few projects in that area where, and sometimes they're interested in like, before integration with like an EHR system and after. So I just wanted to, I just thought of the additional source of data. It's like proprietary product data. So the scale of it, as you can see at the bottom, it can be, this is billions of patient records. Often, we start with like, we'll look at the specific data sets later on, but like EHR data, often the sources is like hundreds, over 100 million patients, like for example, like opt-in data. And we'll get more into that later. Um, so the value of real world data. um, So kind of why does it matter? And I kind of separated this into three main reasons. So we have regulatory decisions. So, medical devices, we're a huge medical device hub here in Minnesota. We refer to it as Medical Alley. Um, and these devices need to go through FDA approval or approval through other regulatory bodies. And what we're seeing is an increasing adoption and use of real world data for drug approvals and medical device approvals. Um, so uh, um, and then another point on this is once you have a product released, um, after approval, you might want to look at safety metrics and like what are what are the side effect profiles for these drugs? And so you maybe look at one drug, what is the side effect profile? Maybe you compare it to like several similar drugs as well. So that's another thing you can do with real world data. Um, and so faster pathways to market. Um, kind of if you think of real world data, it's like data that's already been collected through, various means that we touched on already. Um, as opposed to like an entire clinical trial, getting all of these patients together. Um, it's just there's a lot of efficiency to it, I think, in terms of time and money, where you don't have to put together an entire clinical trial. And it also kind of gives you insight into like how is this drug working in the real world, like when you look at things like side effects and things like that. So the second point is market access. So you have um, like insurance companies need to understand like the cost effectiveness for the product because if they're going to want to reimburse it, so it gives that's one kind of incentive for them to do these studies. Um, Additionally, something called value-based care, which you're kind of proving that they're actually like beneficial outcomes to the product, not just it's understanding like what are the outcomes delivered by this product. Um, so this data kind of once generated, it's real world evidence. It provides like insights for multiple parties to like negotiate the prices of drugs and products. So that's another role it plays. Um, the third role is utility and clinical decision. So like how effective is this treatment? In general, how effective it is it in like certain populations? So understanding that and again, it's like in a real world setting. So this isn't a clinical trial where it's like, some perfect um scenario. It's like actually looking at it in the real world and understanding that. Um, so you can look at kind of all sorts of factors being involved because it's a real world setting. So patients can have like many different conditions. And you can kind of look at the interplay of all of that, using this real world data. Um, so practice patterns, it can kind of, you know, often like publications come out of this, these studies, and then it can inform like practice guidelines and treatment protocols for physicians. So, they can like kind of I gave the example of like side effect profiles. Like maybe if they're looking at like you do a study on three different drugs, and we find that one is has significantly lower side effects. Um, there might be a practice change there, where they think, we can benefit patients by, them having fewer side effects if we prescribe this drug. So that's one example. So so you've kind of seen a shift where before there was a lot of clinical trials, and they're still used quite a bit today, but it seems like so real world data is now central to many business and clinical decisions, and it's projected to grow in the coming years as well. Um, so I have here some of the databases that I've worked with. So just to give you an idea of like what this looks like, and so we have some. These are some major databases. So we have EHR and claims represented here. So you can see really the scale here is very large. So like Optum, for example, combines that's a combined EHR and claims data set that I worked with. They kind of start with the EHR and then they link in the claims data. So it provides like a comprehensive view of like you get a lot of clinical insights from the EHR side, and then you get like kind of the billing and pricing and things from the claims data. So you can see I kind of categorize that as like comprehensive analysis. So more is going to be possible because you have this linked data. So some other external data is a company based in Kansas originally. It was bought by Oracle. Um, Also, I mean, these are all large scale data sets. So you have over 100 million patients. This has been particularly useful in clinical research. Um, I think, yeah, j- just after it was acquired by Oracle, I think the partnerships using the data has kind of been a little more in limbo, and that can happen sometimes. Um, Trinetics is another data set that over 250 million patients, so they have a huge um, patient base, um, and this can be, I think, so multi-site studies. I think EHR data, it's coming from hospitals, so they have like a large network of hospitals that they can use. CMS Medicare data, it's all claims data, and it's like if you want to do a study, it's going to be Medicare patients, so older patients. If you wanted to do a study in this area, that can be a good source. And I think um, the costs like to acquire these data sets can be kind of large, but I think CMS is generally more affordable. Um, and then Market Scan is another, it's a claims data set. It's similar to the Optum claims, similar format, but Optum is going to be coming primarily from United Healthcare. So we would refer to it as like a single payer data set, whereas I believe MarketScan has multiple insurance companies involved. So kind of um, the main point I guess we touched on is the scale. It's a very large scale of records, and as time goes on, they're collecting more data as well. So adding to this as well. And so as you can see at the bottom there, so all of this data is de-identified and HIPAA compliant, which brings me to the next topic. which is data privacy and de-identification. Wanted to touch on this. So we'll talk about how patient privacy is protected. It's very important for this type of research because the data is very sensitive, so we don't want, any of that being compromised. Um, so HIPAA requires removal of 18 specific identifiers before data can be used for research. I give the examples there down below. So things like names, addresses, phone numbers, like pretty straightforward that those would need to be removed. Um, so to do this, they can be removed entirely, or there can be like things like data transformation done. Um, and sometimes like from a zip code, right, you can get something like a state or region that wouldn't be identifying. You can do things to like the dates to kind of not use the actual date, but relate it to like admission date or like condition onset, things like that. Um, so there's different kind of different techniques that can be used. Um, so once we've done this process, um, we'll have things like age groups, diagnosis codes, procedure codes. These aren't going to be identifying medications, lab values, um, things like that. So it's really the relevant data that we need to do the study, but not something that's going to compromise the patient's privacy. Um, so yeah. So let me just I'm kind of navigating. Um, so here's a concrete example of what this looks like in practice. So if you look at the yellow box, that's kind of what, a pre-processed medical record may look like, with name, date of birth, um, identifying information. Um, after, so it's usually there are some specific companies that help with the identification. I haven't done this. Usually when the data that I receive is going to be de-identified. Um, so once I receive the data, it's going to look something like the blue de-identified record. So you're going to have like a patient ID that's assigned to kind of identify that unique patient, but just as an ID, not their any of their personal information. Um, it could be just age group, or just age, so not date of birth, so that that's not being used to identify them. You know, of course, address isn't going to be included, so something like the region can be used. Um, and like day day zero, not the actual date, something like that. And you can see that like clinical information is preserved, which will be the most relevant to the study. Um, so that's kind of an idea of how that works. Um, so the key thing is that patient privacy is fully protected, but research is still possible. You can learn like the patterns that are present without actually identifying the individual patients. So it's kind of like census data is or you can say that 1,000 people in Minnesota have diabetes without knowing who those patients are. Um, so at the bottom, I just want to touch on some of the methods that are used to do this a little more. So we have so tokenization is the process where we're replacing that information with something like that patient ID variable. And we talked about the date shifting, the geographic aggregation to region. So kind of touched on age banding a little bit. Suppression is another technique that they can use where kind of suppress some rare combinations that could identify patients. So I'll move on to the next slide. So some additional research safeguards that can be used. So beyond the identification, um, some of these kind of may be obvious, like secure data environments. I think, often you use multi-factor authentication for things like emails and social media accounts, so it's similar there. Kind of keeping all the queries that are used. Um, Time-limited data access is common. Um, and reviews for data export, that was something that's common, like when you use data from these companies, they'll have that um, in the environment. Um, so analytical safeguards, so cell suppression, so don't report counts of a certain length. So yeah, I guess I don't need to touch on all of these specifically, but these are some examples. I want to get into the legal framework as well. So when I'm kind of signing something with a client, or often anytime there's data being kind of transferred, there's going to be agreements in place that detail all of these things and kind of requirements that anyone working with the data will follow. Like often also like you have HIPAA compliance training and things like that. Um, so yeah, and then also the publication standards as well. So that's going to be kind of an additional standard where it's just like, yeah, no identifiable information in the papers, no um, revealing kind of data or statistics or you aggregated like outcome data, um, and then some of those additional standards. But the So the bottom line is patient privacy is protected at every step, from data collection to analysis to publication. It's super important for this industry, like because we're publishing medical research, and like the stakes are very high to not have a leak of patient information. So now that we kind of got into the foundation and privacy protections, let me show you like some case studies of like actually working with the data. So we're going to touch on 3 published examples. So I just want to issue a disclaimer at the top. These studies were conducted during my tenure at Boston Strategic Partners. I do not own this work. It belongs to BSP and their clients. I'm sharing it here as examples of published healthcare analytics research. Um, so yeah, let me introduce study 1. I have kind of the publication the publications and the years listed there for each study. Um, yeah, the first one is going to be intraoperative hypotension and healthcare utilization. So kind of looking at healthcare utilization is things like I mentioned earlier, where like you look at visits, like inpatient visits, outpatient visits, etc. We'll look at bladder cancer treatment economics, and then an AI-powered subgroup, patient subgroup discovery. So, so the first study, um, it's um, so intraoperative hypotension is so hypotension. Hypo is low, so it's low blood pressure during surgery. So kind of the concept is when blood pressure drops, organs don't get enough oxygen that can be and it can lead to damaging other organs or ne other negative effects. Um, so including like things like kidney injury, heart damage, and increased mortality. So the business question is, what is the economic impact of this on healthcare resource utilization? Um, why it matters? Medical device companies need evidence to prove their equipment has value. So if you have a device that is helping identify this, for example, kind of quantifying what is the value of this. Hospitals also want to know the cost of the complications that they could prevent. Um, and payers, insurance companies, you know, want to know if they should invest in these this technology or these devices as well. Um, so so this study was using the first data set we touched on. It's the Optum market clarity linked EHR and claims data set. Um, so so the reason we needed linked data is because so EHR data generally doesn't it almost never pretty much never has cost data. So in order to look at kind of the clinical side using the EHR and the cost side using the claims, you can do that with linked data. So we looked at about 11,000 patients undergoing elective non-cardiac surgery. Um, the definition of this is so the pressure in your arteries lower than 65 millimeters of mercury for a cumulative of 15 minutes. Um, and we looked at healthcare resource utilization at 30, 60, and 90 days post-surgery. So um, I guess I want to explain more what the HCRU means. So it's going to be things like how many times did the patient have an inpatient stay, like stay in the hospital after this surgery? How many days? How many times did they visit an outpatient facility? Um, how many times did they visit the emergency room? Um, how many, what was their pharmacy use? So things like that. Um, yeah, and so often included in these studies is modeling as well. Not always. It kind of depends on the need and what's being studied. But so often the idea with some of the modeling is like how can we control for certain characteristics in the data and kind of make it more as objective as possible. So controlling for things like patient demographics and clinical characteristics and other things like that. So that's one aspect of it. And then it's also seeing like how another aspect of it can be seeing like what impact do these things have as well. So kind of those are two ways that can be used. Um, So what we found was, how prevalent is this? From the data we can see this. So about 19% of surgical patients experience this based on our data set of like about 11,000 surgical patients. So that's nearly 1 in 5. So it's being seen as, it's fairly common in this data set. Um, and there's different, you can do different classifications for patients. So we grouped the patients by kind of how healthy are they. Um, and that's what that, so we grouped them into classes. And looked at like the different rates, and we found that the highest class was actually relatively healthy patients. So that was one finding, but there wasn't a huge spread in those groups. So the big findings are um, so 30 days after surgery, we saw a 6.8% increase in healthcare visits, which was statistically significant um, using the modeling that we did um, at 30 days. At 60 days, there was a 5.9% increase, and at 90 days, a 6.4% increase. So um, sometimes, I guess one thing I think about is I think um, sometimes the real world data studies um, it's not it's not all like AI. Like when we think of AI, it's LLMs and all that, but there's still a lot of this work being done where there's the data analysis portion, and then there's this other type of modeling. I kind of wanted to emphasize that, but um, if you look at so this will help inform kind of those parties that we mentioned before. Like what is the impact of this disease? Or sorry, not disease. What is the impact of hypotension? Um, and of any monitoring technology or devices that are going to be used to try to prevent it. It could be, you know, decreased, you know, HCRU, decreased healthcare resource utilization, fewer inpatient visits, fewer ER visits. So just helping understand that, and what preventing it, what could be the impact of preventing it. So like for a hospital doing like 10,000 surgeries a year, this could represent hundreds of extra patient encounters to manage, this increase of HCRU. So, or on the flip side, if we're preventing this from happening, much fewer encounters, and better for patients, better for hospitals, saved money. So a lot of benefits. So that's what we're trying to quantify here. Um, so the second study, very different focus. This is health economics. So um, looking at two different treatment options for bladder cancer. So one is a surgical removal of the bladder, and the other is a strategy of chemo, radiation, and surgery. So um, we also did some studies on the clinical impact of this, but this one is focused on more the costs. So, and costs are going to affect the the patient, the hospital, the insurance companies. So it's kind of impacting everyone, affecting everyone. So, um, and part of that impact is going to be pricing strategies, payer negotiations, and kind of value-based care. Um, mm, so let me just, so kind of both treatments work, but how are the costs over the long term? And you'll see more of that later. Um, and that can affect like the pricing strategy for like a pharma company, negotiations with the insurance companies, um, and also like, for the patient, what is going to be the most cost effective strategy. Um, so so we'll look more into this. So this was using Optum claims data, so not the EHR portion, but the Optum claims still has a lot of clinical information as well. So we were able to do this. And this was a much smaller data set, so 839 uh, surgery patients and 484 of the combination treatment. Um, so sometimes studies, can be pretty simple, and this is an example of that, just in terms of like just looking at median costs over time, and just comparing and getting an idea and contributing that to the literature, and providing an updated um measure of this. um so you can see that costs obviously increase over time, but you can see that, what um it gives an idea of the difference in treatment costs. So you can see that, the surgery initially is going to be much more expensive. Um and it pretty much that stays consistent, but it kind of evens out as you go further in time. Um a consideration is the surgery is very invasive also. So like if we can avoid this by and also have um so I'm sorry, at the beginning we see the big cost difference, but over time the combination treatment ends up being more expensive. Um but it's considered a preservation treatment, so we kind of try to balance and consider um, the impact for the patients as well. So, and maybe this has gotten more affordable over time, the combination treatment, but this is not as invasive, and it's not um, affecting you know the fewer uh, the impact to the patient is not as severe as initially as the invasive surgery. So, but kind of the bottom line is we're trying to inform the literature and just provide an updated picture of this. Um, so the third study, um, and this is going to be this an AI powered patient subgroup discovery. Um, so we had infusion. There's a albumin product. It's effective for certain conditions, liver conditions, but it was unclear if other critically ill patients may benefit. Um, so, before LLMs, when we thought of AI, we thought of, it seems like the conversation in AI is it's like almost entirely centered around LLMs, but there are other machine learning algorithms as well. And before the past few years, those were often included in the AI conversation as well. And um, they they share the similar foundation. Um, so this is going to be a machine learning study um, that we use to identify specific patient subgroups that may benefit from this treatment. Um, so we know that this treatment is used to stabilize critically ill patients. We know it works for specific liver conditions, but what about other groups of patients that may benefit? So identifying another group that benefits. Um, so the challenge was we have all these conditions, we have this large data set. Um, how can we identify another subgroup of patients that could benefit from this? Um, so like traditional analysis without trying to apply this would be kind of sifting through the data and trying to test things, each manually and look for interactions between variables and things like that. Um, which would be, you know, it's not very time efficient and so what other way could be used? Um so that's where we can use a machine learning algorithm. In this case, I'll get to that in a second, but so patient discovery in complex data and try to use the algorithm to look for subgroups. Um, so this was from Cerner EHR data, about 360,000 patients, 5 different cohorts. Um, I applied propensity score matching is a method of trying to control for covariates, trying to control for um, things like uh, past medical history, age, so patient variables like that. Um, even region, things control for the other variables that are not of like clinical interest. Um, so that was the first step, and then applying decision tree algorithms to identify outcomes. So um, we have some outcomes that we're interested in, and the decision tree will split the data um, based on those different variables in the data set. It'll split the data and it'll try to predict um, the outcome. So it's it's splitting the data and kind of and then once it splits the data, we can look at, what was the impact on the outcome. Um, in each of these kind of it splits the data into different subgroups. Um, so it would ask questions like, does the patient have liver disease? Is there certain lab value below a certain level? And it keeps splitting until you find groups with different outcomes. Um, so from that, you're gonna get these different subgroups, and you're gonna have um, information about their outcomes, and then you can test the findings on the subgroups and see what the rates are. So in this case, we looked at 30-day mortality as one outcome. So it's basically, I mean, it's the rate of patients who passed away, but it can also be looked at, inversely as the survival rate. 90-day readmission to the hospital, patient's length of stay in the hospital and how many days were they out of the hospital. Um, so we identified this was a key group in the study was a subgroup of 598 patients with severe anemia, gastrointestinal bleeding, and without cirrhosis, and found that they had a 20 about 26% lower 30-day mortality. Um, and we yeah, so 26-day or sorry, 26% lower 30-day mortality. Um, so so identified this group benefiting that was previously unknown, and if you think about typical analysis methods, like how else would you have just found this group and like these conditions, um and so this is one example, but where decision tree as an algorithm, machine learning algorithm can be used to split the data and identify characteristics about some subgroup, subset of the data. Um,
Ian,
so
sorry to
yeah,
interrupt. I'm gonna just jump in.
yeah,
We have a couple of minutes left just to wrap up, and then we'll proceed with Q&A. Just a little
okay,
heads up.
okay. Thank you. Um, okay, so I think we covered that enough. Um, so I just compared these in a table, kind of you have one study was safety economics, study two was treatment costs, study three was getting more into AI discovery, as a machine learning algorithm, how can you subset the data and identify these groups? So common elements of these studies are, real world data at scale. They're very large data sets, billions of records, millions of patients. You're applying a rigorous methodology. Um, some studies, peer-reviewed research, um, and questions that are relevant to the business as well, and multiple stakeholder applications. Um, s- so time allocation for this work would be 40% data work, so things like data cleaning, preparation, acquisition, things like that. 30% analysis, 20% communication to like internally and to stakeholders, and 10% documenting. And you can see the key activities and project timelines listed there for this kind of work. Um, yeah, I think I'm going to be short on time here, but so some of the challenges include data quality and missingness, the different medical coding systems, the privacy and security we talked about, computational demands for these large data sets, and then validation and reproducibility. Um, Non-technical challenges um, can be things like translating the findings for stakeholders, balancing rigor with timeline pressures, understanding context, uh, regulatory documentation, and managing client expectations. So the reality is that success requires both the technical expertise and the business and clinical understanding. Um, yeah, so some points on the data quality as well. I think we touched on some of this, but I think so. This is a key piece though, and a lot of time is spent on this. Um, before you get to the actual analysis stage. So dealing with things like missing data, incomplete data, coding errors, and temporal, like time issues of the data are big. Um, so you know, domain knowledge is big in this field where um, y- you know it's very there's a lot of context involved. So understanding what things mean. Simple. I found that simple methods are often they can be better. So it's like based on the the problem and the outcome you're looking to see. Pick so often the simplest method is going to be better. Um, Stakeholder alignment. So a good enough analysis that answers the business question is better than a perfect analysis that doesn't. Document everything, build relationships with clinicians. And it's an iterative process. So, you know, you kind of do drafts of the analysis and get to a mutually beneficial position um, at the end. Um, so quickly, I'll just this is the company that I founded. So it's Expert Solutions for Healthcare and Life Sciences. This year, founded this year, and the mission is to provide these solutions for healthcare and life sciences. You can see the focus areas there, aiming to provide a direct partnership, as opposed to often this is done like in teams of like 3 to 7, and looking to some clients want to work more directly with the data and be more hands-on. So it's kind of aimed to that's one thing I'm wanting to provide is working more hands-on with the data. So providing these services, um, kind of these five groups are so claims and EHR analysis, real world evidence studies, HEOR, AI and machine learning, regulatory and medical affairs, and strategic analytics. Um, so clients partnerships would be pharmaceutical companies, medical device manufacturers, biotech firms, healthcare systems, and health tech companies. Um, the the products can be the projects can be similar to some that we looked at there. Things like resource utilization and things like that, cost, and patient identification, like the subgroup example that we looked at. Um, yeah, just this is how we would work together. The initial consultation, going over research questions, things like that, how the project would be executed, deliverables, um, and then I have a little blurb on why to work with me on the right. Um, if you or anyone you know wants to connect, I have my contact information listed here, um, and a list of potential collaborations there.
All right. Thank you so much, Ian. Please connect
Yep.
with him if you are more interested in working with him and on learning more about this material. Very insightful material. We appreciate you attending. Now we will move on to about 5 minutes of Q&A if the questions give enough time to. Um, we have already one question coming up here
Great.
for you, Ian. So,
Mhm.
as AI becomes more integrated into healthcare analytics, how can companies balance innovation with the ethical considerations like patient privacy and algorithmic bias? You talked a little bit more, a little bit previously about HIPAA, for instance, in this case, but just considering how AI is being more and more integrated, and it is quite inevitable for it to be fully integrated in many different fields, how could companies tackle this?
Yeah, I think I was thinking about that recently, actually. So I think this is one reason why this field as a whole is kind of more robust to, AI kind of taking over everything because it's so regulated. Um, and because the stakes are so high when in terms of like patient privacy and things like that. So like if you think about like, would companies want to feed, billions of patient records into an AI system? Um, and if just as examples, you think of like the ChatGPT and Claude, that obviously like seems highly problematic to do that. So I think, that's one reason, why analyses will continue to be done kind of the way that they're being done. Um, which is having like data scientists, do these studies, but I think I see it more as being augmented by AI. So like in terms of like like maybe you generate starter code like um for the project and things like that. But I guess the answer take home would be I think I see like humans being like in the loop for this kind of work for a long time uh in the future, or at least for the it's hard to look super far, but for the coming years I think humans in the loop for this. Does that answer the question, or any follow-ups to that?
I believe it does answer the question. Thank you. Let's
Okay, great.
see.
Any other questions?
I'm reading the chat, waiting for some questions here. And this is a personal question of mine.
Hmm.
You mentioned you are a St. Mary's alum. Being
Yep.
an alum of this institution, and I see a lot of quite a few attendees as well that are currently students. To put it simply, like what kind of skills and experiences from your time here at St. Mary's have most influenced your career path? And how do you see different programs like, for instance, the Center of Business Analytics as an opportunity to prepare for roles like yours?
Yeah, I think for me, one of the first things is I minored in math at St. Mary's, and so that gave me a lot of analytical foundation, and it actually gave me the prerequisites to do my master's in data science at DePaul. So that I would say that for the first part of your question. And then I think for the Center of Business Analytics, I think getting a really strong foundation in things like Python and SQL, as though those are the two primary tools used. I think things like Power BI and other tools can also be Tableau can be super useful. And I would say experimenting with different data sets and like trying to get some like domain expertise working with like whichever field you're interested in, I think would be very, very valuable. Because it's not just the technical skills, but it's also like knowing having the not domain knowledge behind the what the data is, and that as well.
All right, thank you. Great answer.
Yeah.
Well, we appreciate your time again. Thank you so much for your presentation. You're doing great work in the industry. Um, Hopefully, you'll be having an even more an increased presence. And thank you, everyone else, for attending to this webinar this afternoon. Just as another reminder, a survey will be provided on screen when this webinar ends, and as well, and you'll have a copy on an automated email. We're always looking for guests, projects, and other opportunities, so please feel free to connect with us. And again, look over in your email about 10 days, 10 business days for a certificate of completion for this session. We appreciate your time. Thanks again, everyone, for coming. Have a nice afternoon.
Thanks, everyone.